Okay, then it is time for us to get started. Welcome, everybody. We're so glad that you could join us for today's community of practice, our prevention community of practice. The title of our COP today is Data-Driven Strategic Planning, Agile Tools for Enhancing Community Outcomes. We're really glad you could make it. This COP is being sponsored and facilitated by the New Hampshire Department of Health and Human Services, as well as Growth Partners New Hampshire Technical Assistance Centre. So we'll just take care of a couple of points of housekeeping before we hand off to our speakers today. We are recording today's meeting, so we ask that everyone please mute your microphone when not speaking, and that way we avoid any unnecessary interruptions. And if you find you're having any internet issues, perhaps if you're finding it difficult to hear the event, you could try turning off your video or joining by phone with the link that's been provided. And if you're having any trouble hearing this event, what you can do is, as you can see on the slide, is expand the audio icon in the bottom left-hand corner of your screen. And then you can select a different speaker from the menu or adjust the volume. Now, one of the things we'd really like during this COP is to have you fully engaged. So we encourage you to use the emoticons under your reactions toolbar, and that way you can express your emotions virtually. This could be in response to something that you hear from one of the presenters. So please feel free to go ahead and use that at any point during these presentations. And please also note that we're going to be using the chat feature. You can find the chat at the bottom of your screen as well, and you can post any general questions that you might have to the presenters. We would ask that you please refrain from posting any personal questions here, as they'll be visible for everybody. And toward the end of the session, if we have time, we'll be posing some of the questions that you've submitted to our presenters so that we can get answers to your questions. So with that taken care of, we're going to hand off to Jill Burke now, who will get today's COP started.
Well, good afternoon, everyone. It's so wonderful to see all of you. We have some new faces, so that's wonderful. About today's community of practice, this is building upon the last year's work that we have done with all of you to begin to focus on data-driven planning and action as it relates to prevention and early intervention. So today, what we hope to do is to bring you through a process that we're looking more at the drivers of substance misuse, specifically how to use data to better understand what those factors are, to select effective strategies and engage community members in that process all along the way. It's a different way of looking at the work we have been doing, whereby it is common that we often will jump immediately to solutions or strategies without fully understanding the intervening variables, or as I mentioned, those drivers behind substance misuse. So today we're going to kind of flip it and make sure that we are diving deeper into that data and using it to plan before we jump immediately to action. We have a very, very busy day, an agenda that's very packed full. So I'm going to end there, but I do want to let you know that this will be one of the last prevention community of practice that I will be opening up and giving some opening remarks. And I'm going to hand that wand over to Kimberly Wade, who has recently joined us. Actually, she joined us last month as our new Prevention Services Administrator. So we're very pleased to have her and very, very lucky. So with that, I'm going to turn it back over to Growth Partners. And again, thank you.
Well, good afternoon, everyone. I'm Lori Barger-Sutter with Growth Partners, and we're going to be taking you through a planning process that we have been using with states and communities and tribes and territories for the past 15 years. We know that everybody has different ways that they conduct strategic planning and work planning. We're just going to share with you today one that we have found works very well. And we've, as I said, we've been teaching and using it with state and local partners for the past 20 years. So I'm going to start with going over the plan and that planning framework. My colleague, Jeff Barr, is going to spend a few minutes talking about vaping in New Hampshire, because we've chosen to use that as the case study based on input from all of you that you are interested in vaping, and that would be a great topic to use as a case study for strategic planning. And then you all are going to spend time putting in small groups, putting this planning framework into action, working, as Jill said, from problem statements to outcomes without getting into the strategies yet. So we're going to go through a process of working through diagnosing a problem and really understanding why it's happening, and identifying the clear outcomes that we want to see before we get to strategies. All right, next slide. So our format is going to be a little bit of presentation and then a lot of time for you all to work in small groups, working through the case study and applying that planning process. So here's an overview. This is our planning process that we use at its most basic. We always start with a problem, and we really encourage people to start with a health consequence, in this case, a consequence of substance misuse. And we do that because while people may differ or disagree about behaviors, what's acceptable, what level of behavior is acceptable, when you're talking about morbidity and mortality and injuries, that's usually a place where people don't disagree. And so we always want to start with consensus, because that's a great way to start a planning process, is starting at a place where everybody agrees there's a problem and the problem shouldn't exist. From there, we look at behavior. So what are those behaviors that are driving that problem? And behaviors might be human, it could be substance misuse, but sometimes behaviors are maybe organizational or institutional. It could be the behavior of in this case, a retail outlet that may be selling vaping products to youth. From there, we look at intervening variables. Some people call them contributing factors, risk and protective factors. And we think of this as the sweet spot of problem solving, because when you understand what the primary factors are that are driving those behaviors that are creating problems, and you intervene with those contributing factors or intervening variables, then you can get a lot of success relatively quickly, and produce significant outcomes. And you can see at that point, and only at that point, then do we begin to think about strategies, because we're looking for the strategies that are specifically designed to control those contributing behaviors contributing factors, excuse me, that lead to the behaviors that drive the problems. And as Jill noted, our human biology, we're just wired to go from problem to strategies. The problem is when we're working with complex problems, that doesn't tend to work very well. We tend to not get the best outcomes, and sometimes we can even make the problem worse when we jump too quickly to strategies. So in our planning process today, we're going to be focusing on those first three. So we're going to start with assessment. You've got a case study. Many of you probably received it ahead of time. If you don't have it or you didn't have a chance to look at it, no worries. We're going to be doing that in session. We're going to be developing a problem statement, defining what the problem is in terms of the health consequence that's occurring. We're going to be settling on a target population. So who is impacted by the problem and who are we going to focus on? We're going to develop targeted goals and objectives, and I'll talk more about that in a minute. And then measurable outcomes, both in the long term, the intermediate, and immediate outcomes. And you can see all of that happens before you select strategies and activities. And you can see those two red balls there. Those are the two key pitfalls of planning. And that is, one, jumping to strategies too quickly before you've really completely diagnosed the issue. And two, defining a problem as a lack of something. And I'll talk more about both of those in a minute as well. Go ahead, next slide. And so I've shared with you some schematics. This is actually a map of the of where we're going to go today. Again, starting with assessment, and which is you're going to use for your case study. Will provide you with the data that you need. From there, developing a problem statement, identifying the target populations you're going to work with. You'll be developing goals and long-term outcomes, which are very much related to goals. I'll talk about that again in a minute. From there, we're going to be going to objectives, identifying objectives, and then identifying intermediate and immediate outcomes. And you can see again, all of that happens when you've completed all of that, when you're really clear on what's happening and what your ideal outcomes are going to be, then you're much better prepared to select strategies that are going to work hard for you. Next slide. Okay, and when you get into small groups, you'll see this template, and this is, we're not going to be completing all of this today, but we're going to be completing key pieces of this. And you can see problem statement, goal. It just lays out in that order that I was showing you in the planning map. We're not going to get into, we're going to get up to the point of strategies and activities and all of the sorts of implementation material. But you can see that this template has basically everything that you need for a strategic plan built right into it. It's got it's got the things that you want to accomplish. It's got your evaluation measures in terms of your outcome. And then it's also got your implementation measures when you get to the very end and you're figuring out what you're going to, what you need to do, what are the timelines, who's responsible, how you're going to measure whether what you said you're going to do is happening and what kind of outputs. We first developed this template about 15 years ago. We were working with a state who had historically had one of the highest rates of underage drinking in the country for decades, and they had been unable to produce significant reductions in that. And so we worked with them. We developed this template for them as a way to kind of very succinctly work through a problem, put together a work plan that had everything they need in it to manage the work plan and monitor it. And I'm pleased to say that state went from being one of the highest rates of, again, of underage drinking in the country. Within 5 years, they had reduced that rate more than 50%. So they went from one of the highest in the country to actually below the national median by approaching problem solving and work planning in this very data-driven and concrete way. Okay. So here's where we're starting. We're going to start with problem statement, goal, long-term outcomes, the first 3 steps in the planning process. Let's go on to the next slide. And as I said earlier, we always start with just a very concise description of what is the health problem that is occurring and who's impacted by it. Next slide. And qualities of a good problem statement, again, it focuses on something that is a consequence, not necessarily a behavior, because we're trying to start at the point of agreement, for the broadest, most general agreement. And health consequences are all the reason that we focus on behaviors and the other things we focus on, because they produce health consequences. It should be supported by data. Again, there's consensus. People agree this is a problem. It shouldn't exist. And there is readiness and political will to solve the problem. So we're starting at a place, again, where we've got agreement, we can measure the problem, and we're ready to tackle it. Next slide. Okay, so one of the things we see is that starting off at problem statements, sometimes people fall into the lack trap, and sometimes we were even trained to talk that way. I know grant writing courses used to teach, I've years ago took courses, and they would teach you to frame things in terms of what's lacking. But the problem is, when you fall into the lack trap, it's another way of jumping to strategies. You're saying, well, there's a lack of enforcement. Say law enforcement isn't enforcing the laws, and so if they would just enforce the laws, the problem wouldn't exist. In reality, we all know it's much more complicated than that. It might be that there's a lack of something, but when we fall into the lack trap, we immediately jump to a course of action, and it can cause us to miss things that are really, really important, and maybe more important than the lack that's in our minds. So we're always framing a problem in terms of what exists that is creating issues for people that should not exist. Next slide. All right. And a goal is simply taking, to create a goal, we simply take that problem and we invert it. So, if the problem is a particular type of health consequence, then our goal is to reduce that health consequence. And at this point, we're breaking the planning into small steps. So we're not worrying at this point about degree of change or time frame for the change. We'll get to that in a little bit. All right, and so prioritizing, and this is an animated slide, Stephen, so you'll need to click through. So we're looking for things that are highly correlated. There's so much noise in data, and there's so many potential courses of actions and things to look at. And so our first step is to look what is most highly correlated to that problem. If we're looking at a behavior at this point, what are the behaviors that have the strongest relationship to that problem? Okay, next one. And then it's got to be actionable, right? It's got to be something that we can actually impact, either through our own actions or through the actions of partners. And then finally, measurable is that if you can't measure the change, if you can't measure what you're trying to change, then you never know whether you're being successful. Next slide. And so again, this is a close cousin to the lack trap, is jumping to strategies. At this point, we're really focusing on what exists, what is happening that's leading to problems. When we find ourselves saying words like train, enforce, provide, we're jumping to strategy. So at this point, we're always focused on using descriptive verbs. We want to increase or decrease a problem. All right. And so long-term outcomes, it's simply taking at this point that goal. It's a good test of your goal. It's making it measurable. So if you're trying to reduce a certain behavior, then at this point you're saying, I want to reduce it by this much by this point in time. And many of you have probably seen this SMART goal. Specific goals or outcomes should be specific, measurable, attainable, relevant, and time-based. And so an easy formula for turning a goal into a long-term outcome is just restating that goal by how much change by what point in time. And if you find that you can't do that, you can't turn your goal into this measurable outcome, then you probably need to go back and revisit your goal. Because again, it's important to be able to measure it and make sure that you can achieve it. Next slide. And then we get this a lot. People ask, well, how much change? How do I know? And our advice is seek a degree of change that's large enough to be meaningful to you and your partners, but small enough to be achievable. Because the success is the best recipe for future success. Last thing you want to do is set a goal that you fall short of. Next slide. Okay, and at this point, I want to ask my colleague, Jeff Barr, who is Director of Tobacco and Nicotine Programming for the New Hampshire Technical Assistance Center, to talk a little bit about vaping, since that's a subject of our case study, and also to to introduce all of us to the case study that he's helped prepare.
Okay, thank you, Lori. Good afternoon, everybody. Well, in this slide, we can see where youth vaping is in New Hampshire. And those first couple just kind of tell us what the youth are saying in terms of if they've tried it in their life and what their usage is during the last 30 days. But what's a bit more concerning are the next ones. And we're starting to deal with frequency there. The frequency that they've used it in 20 or more days in the last 30, and those reporting that they use vape products daily. And you'll also notice that they're bolded, which means that these percentages are higher than the national results. And then finally, we look at where they're getting their vape products from a store. So that's a little higher than the national average. And then, but I will say, working with Ann Crawford and the signer, the last couple of years, we're collecting more data in terms of retail sales. So we're in the beginning stages of dialing in on that information and that analysis to kind of see where the key contributors to that are. Next slide. So today we have a case study. We also sent out to you a couple of articles, research documents. The first research document deals with vaping and the associated traumas, basically traumas that are the result of device mishaps. We thought you'd find that interesting. And then the second one, Massachusetts conducted a emergency response a couple years ago to vaping, where they banned this sale of vape products in the retail location, and you can see the results of that. And then finally, we have an article that deals with New Hampshire. It's from the 2017 YRBS data that the rate for teen use in New Hampshire was the highest in the nation. In terms of the case study, this is fictional information. It's nothing that we pulled from a table from actual data. But it contains the information that we typically look at when we go through this process. This is a fictitious county. It's composed of both rural and a metropolitan area, which has a college in it. The metropolitan area has high academic achievement and income, and whereas the rural area is an older population. There's information in there about the problem that you'll use in the first breakout session. And then there's also some information from YRBS, the behaviors that contribute to the problem. I would like to mention in the problem section, if you've gone through some CADCA training, it's my understanding they inform you to focus on the substance and not the device. But in this case study, we also have information on the device. So that'll take you through for your first breakout session. And then the case study goes into, provides information for your second breakout. And again, we're looking at YRBS data in terms of access to tobacco. We're looking at store or retail environments, online and social. We also have a little bit of information in there about the number of vape shops that are appearing within the county, and also tobacco inspection data, what that RVR, that retail violation rate is over the past 3 years. We have a little bit of anecdotal information that you might find useful, how the folks are unaware of just the broad spectrum of vaping products that are out there, not fully aware of the harm that it can cause, and that there's been limited merchant education. And some other things you may want to consider are the, in past prevention efforts within the county have primarily been focused on alcohol, not so much tobacco, and the tobacco prevention efforts that have been made or deal with the younger kids, which is, maybe not so reflective anymore when we've introduced tobacco 21 within the state. So that's a recap of the case study. Again, you'll see it when you do your breakout rooms. You can refer to it to help you make those decisions as far as the strategic planning template goes. Lori, back to you.
All right, thank you, Jeff. So, we're about to go into small groups. We've got everybody broken into 4. I'll be scribing, facilitating one of those groups. Jeff will be scribing in another with Ann Crawford. We've got my colleague Mana Rose and Jill Burke will be manning another group, and then Elliot and Monica will be facilitating and scribing the 4th group. And we're going to start with that strategic plan template. You can see in red, we're going to be starting with problem statement, goal, long-term outcome. That's your assignment. Get into group, spend a few minutes introducing yourselves, getting to know everybody. And then your scribes will be providing access to the case study so you can look at that. And we're going to spend the next about 20 minutes just going through, filling out, beginning to work through this planning process. Again, problem statement, turning that into a goal, and then turning that into a long-term outcome. So there we go. So take us away, Stephen.
Hi, everybody.
Hi, everyone.
Hi there.
So we will start with some brief introductions. And what I'm going to do is, as I see folks on the screen, I am going to ask that you introduce yourself and what organization you're from. And then we will dive right into our prevention planning. So I'm going to start with Andrea.
Hi, everybody. I'm Andrea Smith. I'm the Substance Misuse Prevention Coordinator for the Upper Valley region. I work at Dartmouth-Hitchcock Medical Center in Lebanon.
Thank you. Carrie?
Hi there, I'm Carrie Lowe. I'm a Resident Services Coordinator for Lakes Region Community Developers Affordable Housing, and I used to be a Substance Misuse Prevention Coordinator in the Winnipesaukee region.
She did. Vicki?
Hi, Vicki Harris with the Dover Coalition for Youth and Dover Youth to Youth. I'm the coalition coordinator over there.
Welcome. Maura?
Hi, I'm Maura McGowan. I'm the program director for the New Hampshire Teen Institute.
Thank you very much. And Mana?
Hi, everybody. I'm Mana Rose, and I'm with the New Hampshire Technical Assistance Center, and I'll be helping scribing today.
Thank you. And I'm Jill Burke. I am the operations administrator here at the Bureau of Drug and Alcohol Services, and formerly had the pleasure of being the prevention services unit administrator. So with that, why don't we dive right in? Here is the case study. It was sent out prior to, I don't know if folks had a chance to look at it, but we are charged first to develop that problem statement and concentrating, as Lori mentioned, on looking at health consequences and impacted populations. So not only the health consequences, but we also need to take a look at who is our target population. So we're very, very clear. And keep in mind, we want to build consensus in our community. So what can everyone agree upon? There's the word. Does anyone want to start to take a stab at what that might be, or want to take a few minutes just to orient yourself to the case study? That might work out better that way.
And if everybody can provide a thumbs up once you've finished reading in your reactions, that would be helpful.
Yes, thank you, Mona. How are folks doing on reading through the case study? Getting close? Okay. So in the interest of time, what are folks thinking in terms of what are those health consequences that we can identify, and that we feel we can build consensus that the community surrounding this particular college can agree upon?
I think the clearly documented ER visits due to health issues. So right in that problem section of the case study.
Thank you, Vicki. Would others agree?
Yep.
Absolutely.
Okay. And so who is the targeted population that the college and the community should be looking at? Who is most impacted by emergency department visits?
High school students.
Folks agree upon that as well? Thumbs up.
Yes.
Okay, thank you. Andrea and Vicki, are you in agreement as well?
Yep.
Okay, with that problem statement, not statement. Okay,
What about location?
yes.
I thought just Balsam County.
And is Balsam County rural, suburban, urban?
I just did the county in general because I think both the metropolis and outside had some concerning information. So I would just encompass the entire county.
Does everyone agree with that?
Yes.
In terms of that target population, so if we're looking at geography, are there any anything that struck you in the data as it relates to the demographic in terms of gender or particular age group?
I think recognizing that there's a college campus there, and I think even though it's high school students that are ending up in the ER, I think it very much trickles into that college population as well.
So potentially expanding like from high school 12 to 25. Okay. So is this problem statement something, looking at this case study, that as prevention professionals, you feel as if you could build consensus on in the community based on the data that you're looking at and what the community is seeing itself? Okay. What do you think we want to change in terms of behavior that leads to the health consequences? What really struck you in that case study?
Past 30-day use.
Okay. Past 30-day use. Was there anything in there in terms of what type of use, or is it so there's past 30-day use? Was there daily use? Was there, I can't, now that I'm trying to remember the case study myself. I mean, not remember, but I can't remember if we saw that.
Yeah, I may have missed it, but I think I'm only seeing the past 30-day use.
Yeah.
And it's saying males and females were using equally. There was an increase in vaping as their grade in school increased, but they didn't really dig into like race, ethnicity, or other characteristics because the survey numbers were too small.
Okay. Yeah. So the behavior is that past 30-day use of vape products, and well, yeah, as you mentioned, there wasn't any real clear trend in terms of male, female, but it was interesting to see as you went up in a grade level. So kind of going back to the doing what we shouldn't be doing, going back to the problem statement as well. But okay. So what is that desired change that we would like to see?
A decrease in past 30-day use.
Okay, so if we state based on that case study, we know that we want a decrease in past 30-day use. What is that degree of change that is achievable, that is realistic and achievable? You know, as we said, we want to make it big enough to make an impact, but also realistic given the time frame. So if we say we want to decrease in past 30-day use, what is that if we say from X, from baseline to whatever that degree of change is, and then by what do you think is a realistic time frame?
I think you look at the data source and how often are you collecting data. So if you're using the YRBS, then it would be an every 2 years. I always struggle with the degree of change. Like that's, I feel like it's just sort of picking a number and not really knowing the community other than like this 1.5-page case study. I think it's hard to throw something out.
Yeah.
And also it's increasing dramatically over time currently. So in keeping that in mind, that, you know, we kind of want to stabilize and push back.
Yes.
I don't think it's realistic to have a very large amount right off the bat.
Would like a 2 to 5% change, is that too small without getting into the nitty gritty? I mean, I think I can't see, I think Vicky talked about with it being YRBS and knowing that like we already lost a year of kind of work with those students, you know, would 2 to 5% be a realistic number, or is that way too small for people, or not?
But given the questions that we just had, the frequency of data, if we're looking at decrease past 30-day use and then every other year time frame, and then also what Andrea just said is, you know, 2 to 5%. Given that we are only getting the YRBS every 2 years,
Right.
what is your recommendation to the group?
So given like all of that you've just said, first think about what is your overall goal. Let's say by the year 2022. Now we have 2021 data coming out now. Look maybe a couple years ahead, what's realistic even with your strategic plan, 2025, for example. Say 10%, but within that, so by 2025, there'll be a 10% decrease in past 30-day use of youth vaping using as documented by the YRBS as an example. But what then you do is you break down that intermediate outcome later, which we'll do, is we can take a year before that, like 2023, and see, okay, are we even getting close to that 10%? Let's look where we might be. So 5% you may want to think about at that intermediate point. So you're looking at benchmark times when you're looking at your outcomes, intermediate outcomes. So think big, but not too far out, if that makes sense. And what's achievable based on what you all know on the ground? What could you realistically do within your communities? Does that make sense?
It does, yeah, thank you.
And I would think that in addition to decreasing 30-day use, we would also want to work towards eliminating those ER visits. So I don't know if we want to combine like multiple outcomes, but if we're looking back at that original problem statement, I would think we would want to address the ER visits as well.
Yeah, I hadn't thought of that. That's, yeah.
Well, when you look at your long-term outcome, if you are reducing your
or reducing use,
yeah. So you're going to want to focus then, get deeper into the reducing use, and then look at the data for ER visits down the line and compare it, right? That sort of, instead of including it in that outcome, then you can say, okay, this is what we did, and this is what happened with our problem. So what do we all think? All right, we got a minute. You want to do 10%?
Yeah, let's go with 10% by 2025.
Okay.
Are folks comfortable with that?
I mean, it's not written perfectly.
All right.
Okay, I think we did it. Our first task.
Yay, team.
18.
Thank you all for making facilitation so easy. I'm gonna mute myself. We have construction in the background.
Okay, Laurie, everyone's back with us in the main session.
Okay, I think we're ahead of, are we ahead of schedule, Stephen? I was thinking we had until 1:58 in small groups.
We must be a little bit ahead of schedule. We did a full 20 minutes in the groups.
Did we? Okay.
Yeah.
All right, we're ahead of schedule then. All right, so we're going to move on to the next step, which is looking for creating objectives. So looking for those contributing factors or intervening variables that are most responsible for driving that behavior, they're most correlated to that behavior. We're going to be turning that into an immediate outcome or intermediate outcome. And then we're going to be looking at creating immediate outcomes. So let's go to the next slide. So following that path, we kind of started with planning is almost like a funnel. I think of it that way, where you're starting with a lot of data and you're narrowing it in with your problem statement, and then you're narrowing in, sifting to that behavior. And now we're focusing in again on, so what are those intervening variables or contributing factors that are most responsible for driving that behavior that we need to control if we're going to achieve our goal. So let's go into the next slide. All right, and go ahead and click again. There. So just like with the behaviors, and even more so now, because these contributing factors or intervening variables are really as I said earlier, the sweet spot of problem solving when you understand when you can identify them and control them, you can get significant outcomes pretty quickly. So we're going to be looking for those that are most highly correlated. Next, click again, actionable, we can do something about them. And then finally, last one would be measurable, right? That again, because if we can't measure the impact of what we're doing, we will never know if we're being successful. Next slide. So one of the principles we find really useful in this work of planning and substance misuse prevention is the 80-20 rule. And this was a rule that was a principle that was formulated years ago by an Italian economist named Wilfredo Pareto. And it's called the 80-20 rule. Let's go into the next slide. What Pareto noticed was that in any group of things that contribute to a common effect, a few of the contributors are going to account for most of the effect. So in this graphic, we see, 20% of the things that you do, you do 100% of things, and 20% of those on average are going to create 80% of the results. Now, it's not always 80-20. Sometimes it's 25-75, sometimes it's 10-90, but the Pareto principle has been found to hold true across all kinds of spheres and sectors. including healthcare. So let's go on to the next slide and I'll show you some examples. So for example, we know from healthcare research that about 20% of patients account for 80% of healthcare costs. And 80% of healthcare costs are caused by a very small number of health issues or contributing factors. So things like smoking, drinking, substance and other drug use, physical inactivity, diet, and stress. Let's go on to the next slide. So in a perfect world, you know, our efforts might look like this red line. So for every amount of effort we put out, we get an equal amount of return. But the reality is that's not really true. You can see this green line that shows us the 80-20 rule, where there are a few things that we could do that will produce most of the effect. The reality is all things are not equal in life. And let's go to the next slide and I'll show you an example of this. So here's a Pareto chart. You can create these in Excel very easily. This particular data, I've been using it for a while. So it's 2016 National Survey on Drug Use and Health. And you can see that it's a chart of access. So for people who reported in this survey having misused prescription pain relievers in the past year, they were asked, where did you usually obtain these prescription pain relievers? And you can see over here on the left that most of them were reporting from a friend or a relative for free, or a prescription from one doctor. So if you really wanted at a national level, if you really wanted to decrease, to impact access, which we all know from research, access is a very significant contributing factor / intervening variable, you would want to focus on these two. If you were focusing on, say, doctor shopping, prescriptions from more than one doctor's, that's the second from the right, you can see that's really pretty low. So you might have some success, but in the big scheme of things, if you really wanted to reduce the misuse or the access to these, you're going to focus on these two. And so that's what we do in the planning process with the Pareto principle. We've got that in mind, and we're thinking of all the things that we could do. What would be the most important? Which are the most highly correlated? Which would have the greatest impact? And in the Pareto principle world, these have come to be known as the trivial many, meaning, you know, of the multiple courses of action, and then the vital few. So of the many things you could do, what are the most vital things to do in order to achieve that outcome? All right, next slide. So again, at this point, like with goals, we have to resist the natural impulse to jump to strategies and talk about what we're going to do, but really still focusing on what are the conditions that we want to change. All right, next slide. So intermediate outcome, just like you did with your goal, and you turned your goal into a long-term outcome, you're going to take your objective, which is basically, you know, that change in the intervening variables or contributing factors, that positive change you're looking for, and you're going to make it measurable. Okay, next slide. And again, you want it to be specific, measurable, attainable, relevant, time-based. So up above, we have a formula, an objective, your objective, and how much change by what point. Okay, and then we're going to ask you in your small groups to come up with immediate outcomes. And sometimes we're used to looking to our strategies. When we jump to strategies and we look to our strategies to tell us what kinds of changes in knowledge, skills, and abilities we're trying to achieve. But here, we're turning that around. We're making the strategies work for us by determining up front, in order to achieve that objective, what kinds of knowledge, skills, and abilities do we need to create or build or strengthen in people? And that's the last step before it. When we know that, when we know what knowledge, skills, and abilities we need to create to control those intervening variables that promote behaviors that leads to problems, then we're really ready to begin looking for the strategies that will work hardest for us. All right, next slide. So again, just like with our other outcomes, we want to make our immediate outcomes SMART. We want to talk about, the degree of change in knowledge, skills, and or abilities. Could be one, could be all three, and by what date. We're going to ask you to create at least one immediate outcome in your small groups. But if you have time, you can go ahead and, generate as many immediate outcomes as you want. That's what we would do in real life. Okay, next slide. So here we go with the template. Hopefully you've gotten through problem statement, goal, long-term outcome. If you haven't in your groups, you'll want to finish that up. I know in my group, we got it done a little bit ahead of time, and we started talking about long-term outcome indicators. Here, again, we want you to go on page 2 of the case study, identify one contributing factor that you think is highly correlated, turn it into an objective, develop an intermediate outcome that reflects that objective, and then begin brainstorming or identifying the immediate outcomes based on that, at least one. And if you have extra time, you can certainly do more than one. All right, and so here we go back into small groups.
Oh, again, it looks like we have everyone.
Hello again.
Is Andrew? Yeah, Andrew's here. Okay. So does everyone understand what we are looking to achieve in this breakout session, which is the immediate outcome? Are there any questions before we get started with regards to that? Okay, so looking at that case study, looking at page 2, do you need us to Mana to pull that back up again? So looking at that case study on page 2, what do you think is the most, or what do you think is the key intervening variable promoting past 30-day use that you saw in that case study?
I think that people aren't fully aware of the harms associated is important, but also the fact that parents and teachers are so unaware of the multiple forms that those products can take is also pretty significant.
So, yeah, and that touches upon the skill, the knowledge, and not skill, excuse me, the knowledge that Lori was identifying. What about in terms of the number of vape shops?
I think that gets into the whole access issue. So it sounds like there's an increase in the number of vape shops around, but also that, these retailers aren't necessarily up to speed on laws or regulations or how they can prevent sales to minors. So it sounds like there's a whole compliance check, access to products issue.
Okay. Anyone else? All right. Were you going to say something, Vicki?
I was just looking through what I had highlighted. And the other thing that stood out is that there's more of a focus on underage alcohol use than there is tobacco use. And I'm assuming that they're set up similar to New Hampshire, where tobacco and alcohol licenses are sort of managed by the same entity. So I think that there's opportunities there as well.
Great. I love how you caught yourself before that you didn't go right to strategies. You just said there's opportunity there. So yeah, I loved it. Anyone else? So in terms of immediate outcome and looking at knowledge and skill and aptitude, where do you think we have the highest correlation, or that we can make an immediate impact on? I mean, I do think there may be two there. So if you took what you mentioned, I believe it was Maura, with regards to knowledge in the community and knowledge in parents regarding the harms of vape products, but also the different forms that they take, how would you turn that into an outcome?
I guess increase the knowledge around the harms associated with vaping, increase knowledge around harms, and increase knowledge around devices.
Okay. Manu, do you have that planning template? It may be up, I just don't see it. There we go. Thank you.
My apologies.
No, that was, could have been on my end.
No, I apologize. So increased knowledge around harms of vaping to whom?
Was it
Of
students and parents?
I would add teachers to that as well.
would would
Yeah,
these
students, parents, and community members, which would also cover the people who sell vapes and vape products.
so those are very distinct populations, right? What do you all think if we combine them? What issues might arise if you look at those different populations, right?
I think there would be fragmentation.
Yeah.
In terms of the ability to get out various forms. So it's almost, to me, it feels as if it is three distinct, or at least two distinct immediate outcomes.
How would we measure the increase in knowledge? I mean, just based on the document that we have, it doesn't look like we have a way to measure that already.
So,
or
yes.
am I missing that?
So the measures, once we create these immediate outcomes, the measures, you start getting into your strategies, activities, and then developing your indicators. What is going to tell us that folks, like retailers, for example, are gaining knowledge, and what are the outputs? So what has happened as a result of retailers gaining that knowledge, like creating those sentences, and then you can measure very detailed exactly, where folks are in the process. Does that make sense?
Yeah, thank you. I just wasn't sure if we could only determine these based on the info we had, or if that was okay that we didn't have that baseline data presented to us already.
Let's see, did we take a look? Does this have any information here? The second, I don't think the second one does. Students, all we know is that folks aren't fully aware, correct? Limited, yeah. Yeah, we don't have the baseline. So that could be the baseline, right?
Good point. I always, Andrew, I always get to that too, especially when I'm writing grants. I'm like, well, I don't have that data. How am I gonna, you know what I mean? So.
And So we said that there'd be distinct immediate outcomes by population, correct? For knowledge?
I felt so. Would folks agree with that?
Do you think we need 3 or 2?
I almost think 3, and the third being students. But
And I
I'm interested to hear what others feel about that as well.
I agree with that.
I don't know how to add another table line, so
That works.
You're doing
perfectly.
well.
That works great. Yeah, I think that the basic message would be the same. They would just be tweaked for the audience. So that strategy would, you wouldn't give the same messaging to a parent as you would to a student, but the information, the underlying information would be the same. It would just be how it would be presented would be different, and where it would be presented would be different. But they all, go together in that messaging, figuring out that, information that you want to get out.
And I think that first outcome around retailers, it's not necessarily so much increasing their knowledge around the harm of vaping, but their role in like best practices and reducing sales. Because at the end of the day, they just care about making money. So I think it's more impactful if they're doing those best practices and sort of reducing sales.
And getting back to Andrew's point, where we're talking about increasing knowledge and not to jump to strategies, but to jump to strategies. It's the way you would measure the parents and communication or community members, I would think would be different than how we would measure student knowledge and skills. Look at us, we have 3.
Well, let's go. Can we take a look at our objective and intermediate outcome? And
Sure, because we're rock stars. Yeah.
So I have here, you all talked about this sort of when we first started this second round. Your desired change, the priority contributing factor is access, right? So you want to look at decreased access to youth vape or vape products to youth, correct? Did I capture that correctly?
The objective, yes. All
right. So then we take that objective, and this is what I was talking about in terms of breaking down that bigger long-term outcome into a smaller, more measurable outcome. So we want to decrease access to vape products by, so we had 10% above. What do you think would be reasonable? What percentage or degree of change are you looking for?
So I think part of the challenge with this one is, the data source that we're looking at is through retail sales. But I think looking at the broader issue, access to these products comes from friends, family members. It's beyond just sort of that retail access. So I think, a smart measurable goal here can be even more complicated if you're taking into account all of those sources.
That's true. Yep.
So looking at trying to see what we had as a data point for, okay, access, okay. Reported, usually getting, store, online, social, other, okay. So the intermediate would be decrease access to vape products by, and so if we're looking at 10% by 2025, what do folks think? I was going to go, like I always do, just by half, by saying 5% to be able to achieve that. But I'd be interested to hear what other folks feel would be an achievable goal within that, knowing that we have the 2021 data when we have it, the next time we administer the YRBS would be 2023. What are folks' thoughts on that?
I think I would be comfortable with a 5% change.
I agree.
As documented by, and I know this is the challenge, right?
Yeah. No.
Inspection data, signer inspection. No.
Wouldn't it be YRBS data since it's youth?
Yes.
Youth stating if they feel it is accessible.
It could be multiple sources of data. That's the other thing, right?
Yeah, I was gonna say there's YRBS data. You know, we're looking for, if you're taking a look at both the YRBS data as reported by students, ease of access, and if we were so lucky to have a question as related to where does one obtain vape products, but then also I do agree that a measurement could be obtained from retail violation.
We also have the hospital data, the emergency room data, which
interesting. Yeah.
You know, we may, and that's going to be more accessible or more often than the YRBS, which is what, every 2 years, right?
Yeah.
So we could see from hospital data quicker than the YRBS, just to even know if we're on the right track.
Very good point. And I like how you all keep reminding me to go back to our problem statement, which is the emergency room department visits. Mona, when you have immediate, so we're looking at our immediate outcomes, when you're looking at intermediate outcomes, you can have multiple outcomes as well, correct?
Correct. Yes.
Okay. So yeah, so as we identified those three data sources, that could that be, I guess is more of a question. Could that be broken down into 3 outcomes, or should we have other outcomes related to? Where I'm going with this is, so our intermediate outcome is to decrease access, but we're also looking to increase knowledge and skill, or knowledge.
True.
So
But as a result of increasing, right, your knowledge, you will decrease access to vape products, right, of those retailers.
yeah, and emergency room. Okay.
Decrease in hospital ED visits by
Mhm.
2023. That's- Sorry, folks, my mom is leaving after a long time visiting me. She just said bye. I apologize if you
Oh.
heard that.
No, we didn't. We
Okay,
can take
sorry.
over from here.
No, it's fine.
Where does she live, Mona?
She lives in Maryland.
Oh, yeah.
So does this look good to you all? Are you all happy with what we've done here? Or we didn't put a date for these? Immediate outcomes. And the degree of change. So we need to talk about that as well. So we're increasing the knowledge of retailers by, well, we don't know, right? It's our baseline.
Yeah.
But we should include a time, a date, or estimated sort of idea of when.
So this is immediate,
Correct.
and we've identified our intermediate as 2023. What do folks think is a realistic time frame? 1 year from today? 18 months?
These seem like campaigns and education training. So I feel like these could be, that 1 year time frame to see a little bit of change.
So 2023. Does that make sense?
Yeah, that's what I heard.
Oops. All right, I think we did it.
I think we did too.
And no one got into the lack trap.
I know. I
Jumping the
was really
strategies.
impressed.
Yeah.
You made my job very easy. And I really think we addressed that Pareto's rule, or what, in terms of that 80-20 rule. We didn't really, we looked at where we had the greatest impact. So good for us. We have a couple of minutes to spare if folks want to, or yeah, I think, grab some water or something.
All right, are we all back, Stephen?
Everyone's back. Laurie, everyone's back in the main room.
Okay, great. And I should have known better than to have questioned you on the time. I did a better job of watching this time when we went in and not just going by our timeline. So I want to spend some minutes. I want to give the groups time to, starting with the group 1, I think, and then going through group 2, 3, and 4, and hearing about how the process worked for people, what kinds of challenges came up as they looked at the data and worked through the process. So I know for group 1, Samantha Durfee has volunteered to be our reporter. So Sam, you want to report out for us, start us off?
Sure. And just to make, did all groups have different case studies?
They all had the same.
They all had the same. So are you hoping for me just to give a quick overview of what our major goal and long-term and intermediate outcomes are looking at?
Yes. And, the things that you thought about, the questions that you had, the things in real life that you questioned and thought about.
Mm-hmm. So we were looking at comparing what's our capacity in our hypothetical public health infrastructure versus where do we, if we have limited capacity and have to look at the most impact. Metropolis, the urban area versus the rural area, has a higher number of students within it who had a larger increase in vaping use. And so if we had to focus on a population, we would focus on that urban area. Though ideally we're trying to support the entire county. Our long-term goal, this is a good test of my memory, Lori. Our long-term goal statement was trying to reduce the 30-day use of vaping products by Metropolis high school students back down to 24%, which was, if it was 2017, 2019, 2021, it was the 2019 rate by the end of 5 to 6 years. So by 2027, we hoped that what had been gained in 2 years, we could potentially reduce over the course of like 5 or 6 years. Thank you for pulling that up. Based on the data presented, we could see that store and social access were highest. We did have a conversation around, there's the most data to create strategies that are measurable and actionable immediately around store violations, like stores that are selling vape products to underage youth. But if our strategies fully focused on just that one access point without employing other strategies around perception of risk, that we did have some concerns around us actually being successful in achieving our long-term reduction in use goals, but it is what it is at this time. And I would reflect that in this conversation, I personally felt, and I support this work in our Public Health Advisory Council for the Capital Area Public Health Network. It's really challenging to kind of come up with what is a realistic and meaningful goal of change. Like how much can you actually think you're going to decrease that percentage point over a certain number of years? So it feels like, we're talking about capacity around our own infrastructure, some of our partner infrastructure, but it's still taking kind of an aspirational guess. Do you want me to dive any deeper into strategies, Lori?
No, I think that's good. Did you touch on the immediate outcomes that you settled on? I'll pull those in.
Because we're focusing on, so our intermediate was decreasing violations across the entire county. There's only 8 stores, so we thought that was reasonable. And even though Metropolis
stores saw a reduction in violations between 2019 and 2021. We still saw an increase in youth accessing vape products via a store in those years. And so there was a concern that maybe they're going into rural communities and still purchasing vape products there. So our target was all 8 stores or any vape stores in the county, and targeting store owners and vendors to increase their knowledge about what the law is and potential consequences or outcomes of them selling those products to underage youth, and then focusing on the youth volunteers who actually have to be equipped to do the compliance checks across the county.
Okay. Fantastic. Thank you, Sam. So I'm going to stop sharing my screen. We'll go back and group 2. You have a reporter for group 2?
Who was group 2?
Yeah, so that's Jill and Vicky and Maura and Andrea and Carrie. So I did not identify a reporter. Would one of you be happy to volunteer to do so? If not, Vicky, can I call on you?
Sure. I missed the end of the conversation. I had to take a phone call, but I think I can work through this. So our problem statement revolved around emergency visits among 12 to 25-year-olds in the county, and had the overall goal of reducing 30-day use of vapes. We struggled to, come up with those measurable outcomes and what was realistic, but we said that we'd do decrease the past 30-day use by 10% by 2025, as according to the YRBS. And then in terms of objectives, we looked at reducing access to vape products in youth, and decrease access to products by 5% by 2023, as documented by the YRBS data, and retail violations. And we also, tying back to our problem statement, said that we wanted to decrease hospital visits by 5% by 2023, as documented by ER data. And then down below, we talked about increasing knowledge of retailers around best practices in reducing vape product sales. And we didn't necessarily put a number, but I guess that would go with the 5% above by 2023. We talked about increasing knowledge of parents and community members about the harms of vaping. And then we also, as a separate outcome, talked about increasing the knowledge among students of the harms of vaping. And we specifically segregated out those 3 populations because we felt like the strategies would be a little different with each of them.
Okay. Thank you.
Thank you.
We have group 3.
Okay, so our goal was to reduce youth vaping. With the long-term outcome, we were thinking about changing that, but we had it as reduced past 30-day use by high school youth within the county. We selected the whole county by 15%. And we used the 2027 YRBS just because I was going from 2022. And then our objective was to reduce accessibility in the retail environment within the county. And we were going to measure that by 20% as determined by the 2025 data. And we did not get to the immediate. We had a lot of conversation about the long-term outcome and thinking about whether or not we should use the past 30-day use as an immediate outcome, but we didn't make any decisions on that.
Okay.
It's a good conversation. We had a nice diversity in the group.
All right. And group 4.
Was that us?
Yeah, that's you, Anne.
Okay, I did the same thing as Jill did. We didn't nominate anyone to present. So do I have anybody? Isabel, I think you would do really good, but I don't want to put you on the spot. If there's
Sure, I
anybody who
can
wants
present.
to.
I
Thanks.
think we've all had very similar ones so far. So our problem statement was really to address the health concerns and injuries related to vaping. Our goal was to reduce vaping among youth and young adults, since that was also some data that we had. And how we are measuring that is with the past 30-day use. And so our long-term outcome is going to be reducing past 30-day vaping rates by 5% by 2025, as measured by the YRBS data. And again, we had those same conversations about what is a realistic number. So we sort of settled on 5% in our group. Our objective was to increase compliance among vape product retailers so that we would really address the environmental issue. And our intermediate outcome, which is how we are measuring it, again, same as all the other groups, we kind of went back and forth about what was realistic, but decrease RVR among vape product retailers by 10% for the entire county, as measured by the county RVR rates. So we only got to one immediate outcome, which was to increase knowledge among retailers and employees. And we started filling out the strategy and activities for those, which I'm sure we'll discuss next time.
Excellent. Excellent. I'm curious, did anybody, I know in group 1, in my group, there was discussion about rural versus urban. Do you focus on one over the other? Do you focus on every? Did those discussions come up in any of the other groups?
They did in group 2 as well. And we ultimately chose to go with the entire county.
Okay.
Yeah, Lori, in group 3, we kind of dialed in on that. Where's, we were thinking of the Pareto. Where's the most bang for the buck going to be? And the other thing I would add is we take a step forward and we get a little bit more information, and we'd go back and massage maybe the goal or the long-term outcome. And I communicated that was perfectly fine. The more you learn, you got to go back and tweak it a little bit. So
yeah, absolutely. We have a saying, it's like, you walk a little farther, we'll see a little more. And it's a good thing when you go back and review what you've done before and see where you need to tweak. It means you've got a good plan process going. Other comments, was it tough to not think about strategies and just to really go through that diagnosis process, or did it go pretty easily for you?
We had a couple reminders, or maybe just like 1.5. It was, once we reminded each other, then it was good. We kind of focused on the goals and the objectives.
Yeah. Excellent. Excellent.
And that was true in group 2 as well. I think the biggest thing we struggled with is how to measure. We were able to quickly identify, well, not quickly, but we were able to identify our outcomes, but in the absence of an identified data source, for example, knowledge of the harms of vape products and the various forms of vape products. In the case study, we didn't have a baseline. So one of the strategies was to establish a baseline, to
Excellent.
to establish that measurement.
Excellent. We had that conversation too. I think there were some strong feelings that perception of harm was a important contributing factor, but there wasn't a data point in the case study. And we talked about the fact that in real life, you might, if it was important enough, you might go and create a mechanism to collect that data and establish a baseline. Good point. Other observations?
One thing in group 2 that, and I struggle with this in grant writing, is how do you select that desired rate of change? You know, you want to go big, but then you're like, oh, what about capacity? And if we're choosing the entire Balsam County, so sometimes that would bog us down. In terms of how do we determine that desired rate of change?
Yeah, I think that is one of the toughest things. And, you know, I go back to that advice that we gave earlier, which was small enough to be meaningful, big enough to be achievable. And so, you know, what is that? Well, as you noted, Jill, that depends somewhat on capacity. You know, what's your partnerships? How entrenched is this problem? But I always encourage people to go on the smaller side, because it's so much better to, like, you know, blow your expectations away and like really overachieve than it is to fall short. And I've seen that happen in communities where, you know, maybe they said a 10% reduction, 10% in 5 years, that's meaningful to them. And then they achieve it, or they achieve greater than that. And it's a great tool for promoting readiness. I've worked in some communities where they weren't ready to work on some issues that were really critical. And so they picked some lower hanging fruit, and they got some good outcomes there. And it built readiness to tackle the things that were more controversial or difficult. So always, you know, it's perfectly respectable to go for 5%, 10%. Our groups were high achievers. We were going for about a 50% long-term reduction in vaping. And so when we got down to the intermediate, I was saying, do you still feel like that long-term outcome is achievable based on your intermediate outcomes? And they said yes, because in real life we'd be doing other things, not just this one, not just targeting this one objective. We'd be targeting retail and social and perception of harm and multiple things. So it's another way to check, is as you get through the planning process, keep checking, you know, what you said you could accomplish based on when you get down to what you're going to do. Any other thoughts or comments?
I know we in group 4 got a little turned around when we got down to the table section of the work. You know, outcome, strategy, activities. People were kind of getting jammed up around what counts as a strategy, how is that different from an outcome. And Catalina popped in with something a pretty handy metaphor. Can you share that, Catalina, what you said?
If I remember correctly. So we were trying to find a way to then delineate more clearly between strategy and outcome, strategy, and activities. Right, in that order. So I was trying to share out how I understood it in my mind. Is the strategy is the approach that one takes to make a difference on a certain topic, and the outcome is kind of the result of what happens after you've tried that approach, and that the activities were sort of a subheading under the strategy of, if, like, in our example under vaping, if you know, merchant education was the strategy, then you know, the activities under that might be, you know, examples of what that merchant education looks like. Is it a webinar to merchants? Is it a payroll? Is it some type of flyer that gets, or is it a personal visit from a public health professional to the business owners? Is it a table at a Chamber of Commerce event or something like that? You know, so those, we're going from more general to more specific, moving from strategy to activity. And then the outcome would be, you know, if all those things had some effect, then the outcome would be greater knowledge. The merchants now have greater knowledge on the topic of vaping. So we were trying to use a metaphor of like baking bread. You know, if the strategy is baking and the outcome is bread, then the activities were, you know, all the different steps that have to be taken to, you know, mix the ingredients and knead the dough and let it rise and then put it in the oven and then set the temperature and then take it out and then let it sit. You know, there were more specific things. I mean, all those things are not bread. There are steps that you get there to get the outcome. The strategy itself can all be described as baking, but baking is not just, you know, cracking an egg. Baking is all of those things that make up all the activities that come under. So going again from more general to more specific to have a result at the end of this, the outcome. So that was just kind of like how I understood it in my own brain, and that's why I was sharing it out.
I think it helped us a lot. So it was good. Yep.
Yeah, that's perfect. That's perfect. And it's a good segue. Stephen, if you could bring up the PowerPoint again. I think we're on slide 41. Next slide. Yeah, and that, how Catalina described it, is perfect. It's exactly how we think of it. It's that big, it's a broad course of action, and that you break down into discrete activities. And our last slide, I'll spend a few minutes just going over that. But so here we are at the end of our planning process. We've gone through, you know, you're doing this for yourself, but you're also doing it for your community or who you're working with, because your plan is also a communications document. You're making a case for change. You're starting with something that everybody cares about in the problem statement, and you're working through why the problem exists. You're setting measurable achievements along the way with your outcomes. At that point, when you know what knowledge, skills, and abilities you need to create, you're ready to select your strategies, and then you go into the implementation and evaluation. So planning, we're going top down. When we implement, we're inverting that. So we're implementing strategies that are ideally hopefully leading to immediate outcomes. And those immediate outcomes are then in turn leading to your intermediate outcomes. And your intermediate outcomes are helping you achieve your long-term outcomes. Let's go to the last slide, or next slide, Stephen. And so here's that template and what Elliot and Catalina were talking about. And as I said, Catalina nailed it. We think about strategies as those kind of big courses of action, you know, baking or merchant education campaign. We're going to conduct a merchant education campaign. Okay, so what are you going to need to do that? You might need to develop or update your materials. You might need to get a list of all the retailers in the county. So the template we use gives you a place to capture all of that. And because it's table based, you can always add rows or as needed. It gives you a place to capture, you know, when does something need to start, and when, if it has an end date, what is it, who's responsible, who's going to carry out each one of those activities, or at least lead it. Process indicators being, how are you going to know, what are you going to look at to know that those activities are occurring as you intended them to? So it could be anything from number of, if you're doing retail inspections, maybe what percentage of inspections have been completed by a certain date. And then outputs in this template just means what are the things you're going to have to create, tangible products that you'll need to create to support or as a result of each of those activities. So again, we know there's lots of different ways for planning. This is a process that we use that we're sharing with you today because we found it's a helpful way to succinctly capture everything, check your logic at every step. And it's easy to communicate among your group and with others, what you're doing and why you're doing it. And I think that is it for our presentation. I'll turn it over to you, Stephen, to close out our COP.
Perfect. Thank you so much, Laurie. Well, thank you, Laurie. Thank you, all of you, for joining us today. It's been fantastic to have you here with us. Thank you for our presenters, Laurie, Jeff, and Jill, our scribes, and our facilitators in our breakout rooms. So what would we like here? We'd love you to visit our website, www.nhtac.org. And this is where you can request any technical assistance and sign up for this community of practice, as well as any others. I know some of you were asking about that in the chat, so please visit this website to sign up for future communities of practice. Once you become a COP member, you'll receive the meeting resources and updates through our Google group, and you can communicate easily with each other, with other group members using this forum. And we're continuously updating this website, so please check back frequently with us here. And lastly, I would like you to check your chat where I'm pasting an evaluation link. So your feedback is so important to us. We'd love to hear what you would like included in future COPs. So please just take a few minutes to give us some feedback and let us know how we can craft these so that they really help you. So once again, we'd like to say thank you to all of you, and we look forward to seeing you again the next time.